it looks specifically at myocardial muscle injury, but there are other things that we need to look at when we're trying to evaluate the cardiac patient. It's not just the cardiac profile, okay? So remember that. We're looking at things like anemia. We're looking at things like, what do you call it? Thyroid toxicosis. These things will give you abnormal lab results that will give you cardiovascular impairment. So you want to look at these, okay? The troponin, okay? It is unique to the cardiac muscle. We look at troponin T, troponin I. It is really unique to the cardiac muscle. The one thing I want you to remember about the troponin is it does not elevate for at least an hour after myocardial damage. So when you have a patient who comes in with myocardial damage, the likelihood that the troponin is going to elevate immediately after this patient starts having an MI are very, very low. Okay? This patient is probably going to have normal troponins at least for the first hour, hour and a half. That's why we do 3 sets. Okay? Because we want to catch it. All right? The troponin gives us a high concentration of myocytes. So if we have myocardial damage, it is going to be elevated. However, you have a patient who comes in with chest pain, a substernal chest pain, and they're doing this. This, by the way, you put your fist to your heart, it's called Levine's sign. Okay? Levine's sign. It's not in your PowerPoint, but I want you to know it. I'll tell you when to type. Yes. And you take their fist and put it over their heart. That's Levine's sign. It's indicative of myocardial disease, angina, myocardial chest pain. Okay? It is released in very small areas of myocardial damage, 1 to 3 hours post-injury. It doesn't start rising for a while, right? What is the first EKG sign of myocardial damage? No. Tall peak T waves. Tall peak T waves are the first thing you see when someone's having a myocardial infarction. So they're going to come in with tall peak T wave, chest pain that radiates to the arm or the jaw, okay? Usually what you see, and their troponin levels may be normal. And at the immediate onset, if they happen to be in your ER or in your ICU, when they get this MI, you're going to see tall peak T waves. Okay? Remember, the troponin stays elevated the longest. It's the myocardial marker that's elevated the slowest, but it stays elevated the longest. So it will be elevated for 4 to 15 days. 14 to 15 days, I'm sorry, I said 4. 14 to 15 days. That's when it starts coming back to normal. It is the last to elevate and the last to go down. Is troponin only elevated in MI? No. Strokes, renal disease will also elevate your troponin. You gotta be very careful, okay? Because you have a patient with a subarachnoid hemorrhage, they can have stunning of the myocardium, and they will have severely elevated troponins. Yes? They can have a stunned myocardium. They look really, really bad. Okay? And those patients, they don't do well. Okay? So you can have it. Strokes can get you an elevated troponin. Renal disease can get you an elevated troponin. You have to be very careful. You have to look and see what's going on with your patient. Okay? CPK is usually second to be elevated, and it's more specific to diagnosing cardiac injury also. The first to be elevated, because I don't know where I have it there, is your myoglobin. Okay? Your myoglobin elevates within the first hour of a myocardial infarction. I think I have it in the hour.
It's there. It's supposed to
It's
be
there.
there.
It's there, right?
It's there.
Your myoglobin elevates first. So first one to be elevated. So if someone comes in with tall peak T waves, chest pain that radiates to the jaw, okay, an elevated myoglobin and normal troponins, they're likely having an MI. Okay? Especially if the pain started 20 minutes ago. You're not going to see elevated troponin. So don't say that the person didn't have an MI. Okay? Do not rule that out. It's more specific to myocardial muscle. It is more specific. Remember, myoglobin is not very specific. Okay? I go and I run an ultra marathon or 100 miles. My myoglobin is going to be sky high. My urine is probably going to look like a straw color. I'm going to be in rhabdo for days. Doesn't mean that I'm having an MI. Okay? But myoglobin is going to be very high. My CPK might be elevated also. Okay? CPK and CK, found in high concentrations, the heart and skeletal muscles. Again, doesn't mean they're having an MI, but likely they may have an MI. Okay? If they have rhabdo, it will be elevated. If they have muscle injury, it can be elevated. Okay? They have some kind of muscular disease, it can be elevated. It's not very specific to the myocardium, so you have to be very careful. So you have to be very careful. Okay? Muscular dystrophy, CNS disorders will all elevate your CK, CPK. Okay, so you gotta know what's going on with your patient. CKMB, circulatory enzymes, skeletal muscles, they'll be elevated. Someone who has damage to skeletal muscles, very likely that this will be elevated, so you want to pay attention to that. Okay? It can be cardiac. It can very well be cardiac, so you want to pay attention. CKBB, it can be brain. Okay? That will elevate that. CKMB is more cardiac than anything else. Okay? So that's really specific to cardiac disease. And it rises 4 to 5 hours, 4 to 6 hours after an MI. It returns to normal in 24 to 36 hours. So this is very important for your CKMB. Mrs. Smith is a 54-year-old male that is admitted to your cardiovascular intensive care unit post cardiac cath and stent placement to the LAD status post in MI. Okay? He's sitting in your ICU and he starts complaining of severe chest pain again. He just had the cath done 2 days ago. Okay? And he's complaining of chest pain again. You look at the ECG and you see a little bit of changes, but nothing really crazy. What lab are you gonna draw? Troponins, yeah, but troponins don't drop for about 14 to 15 days. So how do you know it's not the same elevation that he had for the MI that he got treated with just a little while ago. The best marker at this time is your CKMB. Because your CKMB comes back to normal in 36 hours. So in about 3 days, your CKMB is already back to baseline. So if it's high again, then you know that person probably has some more insult, myocardial insult. So the best one to check at that point will be your CKMB. Okay? It's very specific to cardiac muscle. One, and in 3 days, it's already back to baseline. Okay? And if it's 2 days, it's probably going back to baseline. So then you want to check it again because it may elevate again. Does that make sense?
So you'll see it trending down and then a spike.
And then it's back again. Okay? Troponins again, it's harder to tell. If they're elevated, if they were elevated because the person had a really large MI, they're going to be really elevated. You won't know if they're elevated from that MI or if they're re-elevating again because this person having another infarct. It's hard to tell. So a CKMB is probably the best measure at this point. Okay? Brain natriuretic peptide. When do you want to check that? CHF patients. How does that work?
Just like when you find resistance. When the vessels are like working too hard.
Heart's working too hard. Usually what happens is, remember aldosterone helps you to hold on to salt, and of course water follows. Where salt goes, water follows. So you have increased fluid volume states. When increased fluid volume states, when you have too much volume on board, the brain says, what's going on here? We need to get rid of some of this. So it stimulates the release of brain natriuretic peptide. Brain natriuretic peptide shuts off the effect of aldosterone and ADH. So in this case, they let go of their salt and they let go of their water along with it. Okay? Brain natriuretic peptide is not specific to CHF and it's not diagnostic of CHF because it may be elevated in someone who's had who has fluid on board for a very long time. So even if the brain natriuretic peptide is low, it doesn't mean that they don't have CHF. Okay? The brain natriuretic peptide is only going to be elevated when there's way too much fluid on board. So if I already treated them and got their fluid off, that doesn't mean their CHF has gone away if the BNP is normal. Okay? The brain natriuretic peptide is not diagnostic of CHF, but it's there to tell us that there's too much fluid on board. Okay? Now, if there's too much fluid on board, brain natriuretic peptide increases to block the effect of aldosterone and ADH, which causes the body to hold on to salt and hold on to water. Does that make sense? Okay. High levels found when the heart needs to work hard over longer periods indicates that there's too much fluid on board, indicative of heart failure because there's too much fluid on board. However, it's not diagnostic for heart failure. It's not a diagnostic test. So we're not doing it to diagnose heart failure. We're doing it because we want to see if there's too much fluid on board. Okay? The absence of an elevation does not mean that that person does not have heart failure. Okay? Make sense, guys? All right. So this is what I want to make sure that you guys get, because you do have test questions that reflect this graph right here. So myoglobin, okay? Look at how early the myoglobin peaks in an MI. Within the first hour, your myoglobin peaks, okay? Your CKMB, usually an hour and a half, 2 hours, depending on which book you read. Most give you about an hour and a half to 2 hours, okay? Now your troponin, look at when this thing peaks. It's usually about 2 hours, can be 2 hours to 3 hours before the troponin peaks. Okay? And then look at how long it takes to come back to the baseline. And this is a really forgiving chart, because most charts go all the way to about 14 days. Okay? So again, it's really important to know this, because if I'm talking about a person re-infarcting their myocardium, you want to know that you're going to check the CKMB and not the troponin within that short period of time, because the troponin is likely going to be elevated still from the first MI. So for reinfarction, you want to check the CKMB. Okay? To initial infarction, what's going to be elevated within an hour? The myoglobin. Okay? Your CKMB and your troponin levels are going to be normal. So your test question is usually going to have an elevated myoglobin, normal CKMB, normal troponin levels, and they're going to ask you what's going on with this patient. And they're going to have all the signs of an MI. Don't say it's musculoskeletal, please. It's not the answer. I'm telling you now, don't choose D. Well, it might be D for you, I don't know. Okay? Don't choose musculoskeletal, it's likely cardiac. Okay? You want to pay attention to that. Especially if you have a EKG that has ST elevation. Make sense? All right. We have just a few more to go. I just want to go over the EKG really quick, and then you guys are out. Some of this we already did in our diagnostic slides, so we're going to skip across some of the slides. Okay, PR segment, we talked about it. What does a PR segment indicate? PR segment, guys. P wave tells you atrial contraction, okay? Time it takes the stimulus to get from where? Atria. Ventricle, okay? Elevation, the one time you ever have a PR segment elevation is in pericarditis. Depression usually indicates it can be pericarditis or atrial infarction.
Like
The
34.
Q, huh?
Like 34.
Oh, I'm sorry. Thought you guys are following me. Slide 34, slide 35 now. QRS. How long is your PR segment supposed to be, by the way?
120. 120.
Yeah.
It's 0.20.
Is it 0.20 or 0.12?
20.
Oh, from 12 to 20. You went that.
Oh, your QRS.
No,
It's just a PR
PR
segment.
segment.
It's just a PR segment.
QRS segment is usually 0.8 to 0.10. Some books say 0.8 to 0.12, depending. Okay, and then some books show 10 to 12 as some lengthening. Okay, shortening of the QRS, so narrow QRS, usually indicates that there is some what you call it? Decreased conduction time when you have a narrow QRS. Okay. Long QRS usually means there's a block. R wave. What does the R wave indicate? When we're looking at an EKG, we're looking at R wave progression only. That's the most important thing that you're looking on an EKG for, is R wave progression. And the reason we look at R wave progression is because it can tell us a lot about what's going on with the patient, okay? Your R wave is usually nice and small in V1, and as we get all the way to V6, it gets nice and tall, okay? If your R wave, if you have a big R wave in V1, it usually means that there's some kind of pathology going on, okay? And a lot of times, posterior wall MI can give you an elevated R wave in V1. Left bundle branch block can also give you an elevated R wave in V1, okay? These are the things that you usually look for when you're looking at your R wave progression, okay? So the abnormal R wave progression is indicative of some kind of disease or some kind of pathology that you want to look for, okay? Causes of R wave to S wave ratio being low. These are all the things that can cause it. I'm not going to test you on them, but just so you know. T wave, ventricular repolarization. T wave should be upright in most leads, except AVR and V1. All we need to know right now is the normals. I'm not testing you on the abnormals, so I want you to know that the R wave should be elevated. I want you to know the length of the PR interval. I want you to know the length of the QRS. I want you to know what the T wave indicates. We talked about what the P wave indicates and all that already. Does that make sense? All I'm doing is making sure you know the normals. The abnormals, I can't teach you because they told me I can't teach EKGs in this class, so, which I think sucks.
Well, I have a question. Excuse me, for your test or when you test us or whatever, or whatnot, the QRS, is it 0.08 to 0.010?
Yes, I mean, I'm not gonna ask you, oh, is it 0.8 or 8, and then I'm gonna have another choice that's gonna be 0.010. No, because it depends on which book you read. Some say 0.8 to 0.10, some say to 12. So it depends on which book you read. So no, I'm not gonna ask you that. I'm just gonna ask you if it's gonna be 0.8 to 10 and then 12 to 14 or something like that. They'll be way off. But what I want you to know is normals. Okay? All right. Remember that your, whatchamacallit? That's not what I want. Your P wave needs to be upright in lead 2. If your P wave is not upright in lead 2, it means that the impulse is not originating from the SA node. Okay? I'm going back and forth because I've gone through this with you guys already. We went over these, but I want you to know what I want you to know. Does that make sense? I want you to know what I want you to know. If your P wave is not upright in lead 2, it usually means that your action potential or your electrical activity is not starting in the SA node. Okay? You either had a junctional rhythm or something like that. Okay? So P wave, atrial depolarization, we talked about it. QRS, ventricular depolarization. T wave, ventricular repolarization. The PR interval, atrial depolarization plus delay in AV notch, AV hiss. Remember that there's a slight delay so that we can actually get the action potential down to the ventricle. Okay. PR segment, we talked about QR, we talked about R wave progression, we talked about T waves. QT intervals, okay? QT interval is the time the heart goes through a whole depolarization to repolarization, okay? And it should be, between 0.4 to 0.44 seconds. You can also measure a T wave ends at half the waypoint through the R to R interval. If that is prolonged, you have a prolonged QT interval. QTC is the corrected, okay, QT interval, and it's a mathematical formula that they do to detect the QT, because there can be variations in QT depending on what's going on with the patient. So you want to make sure you do the QT or corrected QT, and your machines, most of them do it for you. Most of the times you don't have to do it, you just put it in and they actually do it for you. Okay? So this class, you will not need to calculate it. Okay, at all. SD segment, this shows that the most active part of ventricular depolarization, okay? And your SD segment is what you look at when you're looking for myocardial infarction or myocardial ischemia, okay? His SA node, of course, is dominant pacemaker. AD node is the backup, ventricular cells. We talked about those, okay? Normal sinus rhythm, this is usually lead 2. Remember, your P wave is upright in lead 2. Look at this one. Where's your P wave? It's gone. This usually means that there's no SA node activity. Okay? If you have P waves, a whole bunch of P waves, and no QRS, usually means that our SA node is firing like crazy, and probably stretched because of heart failure or some dysfunction of the SA node, and you have, of course, atrial fibrillation, okay? Remember, in atrial fibrillation, you have no atrial kick. I can't say that enough. We talked about this. We talked about this. We just talked about these. And that's about it. I want to talk to you about these for now. 725. Look at that.
Drum roll.
Yeah, don't get used to it. Ask some people who had me for Pablo. That doesn't happen often. We're done.
Hey, Jerry?